We have Jaffer Ajani from MD Anderson Cancer Center, who's going to give us a wonderful talk on non-surgical items. He's also the chair of our medical advisory board. So let's welcome Dr. Ajani.
Good morning. So I have a difficult topic, but I should have brought some additional slides. But I want to address some of the issues that were already mentioned and provide you a source where you can get more information. One is the nccn.org. That's the National Cancer Center organization. And we have a new module in there, and Dr. Ilson is actually helping with that, and that is for genetic testing. So if you're concerned that your siblings or your children may be at higher risk, you should really read the document because it is produced by a number of experts around the nation. And we'll try to get Dr. Norton on there. The other thing I wanted to mention is the BRCA gene. So somebody who has a mutation in BRCA gene, they are at higher risk for gastric cancer, and we have seen several patients. So someone mentioned if you don't have CDH1 mutation, what other genes to look for? And BRCA is one of them. And there are probably several more to emerge where there is clustering of gastric cancer in the family. And the other thing I wanted to mention is about the HIPAC, which is intraperitoneal therapy of chemotherapy with a very high temperature solution. So I completely agree with Dr. Norton and others. So one of our surgeons, Dr. Mansfield, and one of the anesthesiologists went to Japan about 10, 12 years ago and went to an institution where they were doing this HIPEC intraoperative treatment of the peritoneal cavity in patients who had a lot of cancer. So you could actually see the cancer and then treat the cancer. And they were reporting results that were very encouraging. So Dr. Mansfield went with an anesthesiologist, came back. We bought all the equipment, a very complicated procedure, and we treated 40 patients. And unfortunately, our group never published that. But I was helping from the medical oncology side, and ultimately we had to shut down the program because we saw really no clear benefit. So if there is known stage 4 disease, and it's in the peritoneal cavity, it's being done around the nation. People are still doing it. But our experience suggests that it probably should not be pursued. However, the surgeons keep bringing it back. So one of our surgeons now has a protocol where we'll be doing it in a different setting, where we are trying to do it in patients who are at high risk of developing peritoneal cavity metastases. So we'll be doing it again, but we'll see. Okay, let's see. So those are I don't have any conflicts to. So we're gonna look at, I'm not going to show you many slides. I have only like 3 slides to show you, but perhaps we can have some dialogue about this very difficult problem. So this is a little bit of a complicated slide. Is there a pointer here? There is one, right? Okay, I'm going to try to use this screen. So first, let's just start with what we have known as medical oncologists for so many years in the clinic. So what this first circle represents, just forget about the numbers or the letters inside the circle. First, this circle represents the entirety of the tumor when a patient has stage 4 cancer. Just imagine the volume. And for many years, we just acknowledge that patient has the stage 4 cancer. We choose what we think is the best treatment. We give it to every patient who has stage 4 cancer. That's what we have done for years and years. So then when the best treatment and treatment number 1 is started, they of course get many cycles, and sometimes we check here. But in many patients, fortunately, the cancer shrinks down. And then we say, well, the tumor is responding to this treatment, so we continue. So you can see that the treatment continues, and eventually the tumor grows back. And this you see over and over and over. There are a few exceptions, but most patients have this pattern. So what do? We repeat the same thing, but instead of treatment number 1 is treatment number 2. This time 0, when we start treatment number 1, to we actually acknowledge that the cancer has grown, can vary considerably in individual patient. This is probably related to all the different genetic makeup of each person's tumor. And it can be as long as 18 months. There are exceptions. I have patients who have documented stage 4 cancer, and after 5 years, they don't even come back because they're tired of getting those scans. So there are patients who do extremely well, but most patients don't even have this 18 months. It's usually about 6, 7, 8 months where the cancer, the first treatment number 1 is no longer effective. So we do treatment number 2, and the same pattern can be observed, but this duration of 6, 7 months is reduced. It's like 3 months or 4 months. And then when you do treatment number 3, the tumor may not even respond. So in other words, more we treat the cancer, more resistant it tends to get. So there are many theories as to why this is happening, and I think Dr. Adam Bass may have mentioned that. But one of the things we know for sure is that if you look at the cells within a given tumor, there are multiple populations. So what I called here is the sensitive population is the S, intermediate population, and then there are some resistant cells. You can call them stem cells. That are highly resistant to any treatment except for surgery. So you can give chemotherapy, radiation therapy, targeted therapy. These population of cells are often resistant. So one way to try to explain this is that you have a lot of sensitive cells in an untreated tumor in a patient who has been diagnosed to have stage 4 cancer. And the treatment number 1 is effective because tumor is smaller, and we can say all the sensitive clones are eradicated. So what we are left with are the resistant and intermediate clones that will grow back, and it will reconstitute. It will again reconstitute as sensitive, intermediate, and resistant. But I put down this time, instead of S, I put down S1, because that's a sensitive clone no longer to the treatment number 1. It's sensitive, hopefully, to treatment number 2. But what I did was I increased the number of intermediate clones and even more resistant clones, because this is what we see in the clinic, is as I mentioned, as we treat the tumor and tumor keeps getting resistant, more treatments we give. And this can happen even without treatment. So the older the tumor and bulkier the tumor, more likely the response duration will be short, or even response may not occur. So what should we do about this? This is one of the things we are hoping as we go forward is that we can figure out which particular treatment is going to be effective. That's number one. But the most important thing is to prevent the cancer from growing back. And we want a very long duration so that we can have maximum advantage of each treatment we give. We want to have the longest and maximum advantage. And that hopefully will come with the testing of the tumor, and for us to not only just figure out which genes are altered, but which genes are actually driving that cancer, which genes are really helping that particular patient's cancer to grow, and then interrupt those proteins. So hopefully we will get more sophisticated. Our colleagues in breast cancer arena and ovarian cancer, they have become much more sophisticated. So as I will show you in the next slide, the number of treatments we can offer to advanced gastric cancer patient is pitifully much lower than what a breast cancer patient with stage 4 has available. And that's unfortunately because we haven't really pacing with the breast cancer community to do as much research as they have done. If you just look at the number of breast cancer trials that are published, it's like 10 times to maybe 50 times more than what we have published in gastric cancer, and that's unfortunate. So the goal, as I mentioned, is to prolong this duration from the original tumor to the tumor that is growing back. And if we prolong it, it gives us more time. We will become smarter. And then at this juncture, when the tumor is bigger, our testing for that tumor will be more sophisticated. So we can then test the increasing tumor and figure out exactly what treatment, either it's a single drug or combination. And we know the single drugs have very little effect, even if you know that is a so-called driver of that tumor. The effect is very short-lasting. That's because the tumor genome is highly sophisticated. It has all these methods to overcome resistance. And it's just trying to survive and driven by survival instincts. So I'm sorry about the color. You are not probably able to see it well. So for these are the drugs in the color that you cannot see. I'll have to read it out for you. So we recommend and test for this HER2 protein on the tumor, and it's unfortunately it's a very small fraction of patients whose tumors are using this protein to multiply. More patients we study, less patients have this protein. So generally speaking, it's about 8 to 10% of patients will have this HER2 protein in sufficient quantity that we can offer this treatment called Herceptin or trastuzumab. And for example, Debbie and there are others in the room who have benefited from addition of this particular drug. But many patients, even if their tumor is using or seems to have a lot of protein on the surface, you give trastuzumab and they don't benefit. So I think we have more research to do to figure out exactly, even all HER2 positive tumors do not respond to Herceptin. And so we have more work to do. Then the chemotherapy, so that's the only drug that is currently available. I think Dr. Ilson will mention about the ramucirumab, which is just approved, but it also has a very marginal effect. And then we have chemotherapy drugs. We have like these 4 classes. One is the platinum compounds, so it can be oxaliplatin or cisplatin. Some people use carboplatin. So in this class of drugs, we have several agents that we can use, and most patients get this. And so I wanted to just mention, I have some patients with BRCA mutation, and they do extremely well with this group of drugs because platinum compound break the DNA through and through, like both strands of the DNA are broken. And if you have BRCA mutation, you cannot repair that. So patient really gets tremendous advantage. So this kind of a ironic situation is that you're born with a defect for not being able to repair the double-stranded break in your DNA that leads to the cancer. So you get cancer because you can't repair your DNA. And when you get the cancer, and if we break the DNA in the cancer, then the patient has the advantage because the tumor also cannot repair the double-stranded DNA. Then we have another class of compounds, camptothecin, but only one of them, irinotecan, has been shown to be beneficial and usually used in as a second treatment, not first treatment. So I should say that platinum compounds are consistently used as a first treatment, one of the components of the first treatment. And the third category is called taxanes, docetaxel or Taxol. These are either used in the first line or often in the second line. And then finally, one of the very old group of drugs called fluoropyrimidines, and you have an oral drug called capecitabine, another oral agent which is S1, not available in the United States, but available in Europe and Asia, and then the intravenous 5-FU. And these fluoropyrimidines are also used in the first line. So this is all we have, and we exhaust these fairly rapidly. So I have many patients, unfortunately, they're highly functional, and they want treatment, and we don't have treatments that are highly studied. Then I have to send them to our phase 1 group, a group of doctors that are studying some of the newer agents, and that's also a very good thing, but unfortunately, it's a different category because we don't really know a whole lot about those drugs. So patients who are relatively healthy, haven't had much treatment, we don't have many treatments to give them, they end up getting very new drugs, and they are not selected. In other words, we have the drug, and the patient wants some treatment, needs some treatment, we just give it to them. So it's not very smart, and we have to do a lot more work to get smarter. So I don't really know, because I came late, whether anything was mentioned about what the future may become promising by enabling our immune system to recognize the cancer and kill the cancer. So this is a new frontier in cancer treatment, and there are many, many, many ways to try to take advantage of this knowledge. One simple example I give you is the Herceptin that many of you may be familiar with. So there is a drug where Herceptin is hooked up to a toxin. So it's linked to a toxin. And then you inject it intravenously. And then it will go to HER2 protein, and the cell will swallow the Herceptin with toxin and the protein, HER2 protein. It swallows, and once the toxin gets inside the cell, theoretically it's supposed to kill the cell. So that is just one example. Here are some examples of the different drugs that are being developed. So what we obviously know is that many patients who appear very healthy, their immune system is probably working just wonderfully because they're not coming down with bacterial and viral and fungal infections. So the immune system is working well, but it is not working against the cancer. It's not recognizing the cancer. And one has to wonder why, because the immune system has the tool to recognize a cancer cell, because cancer cell is considered a sick cell. It's not considered healthy cell for the host. So it is an unwanted cell, and yet the immune system ignores it altogether, and we don't really understand why. So it may be because it is part of the reducing the autoimmunity, because our immune system does not normally attack our normal tissue, because there is this program to recognize normal protein and leave those cells alone. And there are many normal proteins on the cancer cells, and maybe that is the reason. So drugs are being developed to stop that juncture where the immune system says, this is one of us, and we need to leave the cancer cell alone. So then this is the T cell which can actually kill the cancer cell. It has the receptors. There are 6 of them recognized. 6 of them are just the antagonists of the inhibitory receptors. And there may be many more. So the drugs that are being developed is to stop the signaling through these receptors. Just 2 of them I show you as example, CTLA-4 and PD-1. And CTLA-4, the drug that stops this messaging through this receptor is already approved for melanoma. And we have studied this in gastric cancer, and some patients respond dramatically. So there is hope that even advanced gastric cancer can be recognized by the immune system through more research. So actually most patients do not respond to these molecules. There is another one that interacts with the PD-1. So there are only 3 drugs in the clinical trial, but I suspect there will be many more. Every receptor you see here, there will probably be drugs available. So this is the second way. The first way, as I mentioned, is what is called conjugates. You take the protein, hook up a toxin, and then you try to kill the cell, because the protein will find the cancer cell and toxin will kill the cell. Then this is the second method, where you enable the immune system to recognize the cancer, and hopefully it will kill most of the cancer, usually not all of the cancer, because as I said, cancer cells are very, very smart using our genome. There are many other ways. So one is developing vaccines against the proteins, abnormal proteins that tumor have, and that a lot of work is being done. And another thing that we are hoping to do is to take out the T cells from a patient, take out a large number of T cells, and then train them outside the patient's body with the tumor protein. So you kind of drug the T cell with the protein of the tumor. So then it hopefully will say that I don't like this protein. This is a danger to the host. And then once it is the T cells are trained, you can expand them. This is still outside of the patient. You can multiply those T cells in millions outside of a patient, and then inject the trained T cells in the patient. And this is called cell therapy. You can look this up. In melanoma, this has shown some benefit, and is being done in many institutions. So we have, fortunately, one gentleman who is an expert in immunobiology and immunobiology of gastric cancer also. So we're hoping to start this program where we will try to train all these T cells, multiply them, and then infuse inside the patient. So there are many other ways where we can exploit the fabulous immune system we have to attack the cancer. And I think hopefully that will be our future, because when you learn about the cancer genome and you take one drug to disrupt that particular gene, as I mentioned before, the benefit is minimum. So you can find two drugs attacking two genes or a pathway. There also the benefit is minimum. So we can keep kind of challenging the cancer genome, and it will become smarter and smarter. But with the immune system, you kill the whole machinery. The goal will be to just take the cancer cell and destroy in its entirety. So you don't allow it to become smarter. I think that may be overall a better way, but we may have to combine the two approaches. So I think I'll stop with that. Thank you very much.
Thank you, Dr. Ajani. Opening it up for questions. We have one in the back, right here. And then we have a question over there.
The FDA just recently approved a Lilly drug called Cyramza. Are you familiar with that? Can you talk about it all?
Yes, I think I'm going to leave that for Dr. Ilson, because he has slides on that. And if he doesn't, then I will come back.
Okay, we have a question over here on the right side of the room.
Yeah, I just wanted to ask about, since I'm familiar with the use of cisplatin in osteosarcoma, could you elaborate more on the underlying mechanisms promoting the efficacy of cisplatin in osteosarcoma, which has a high response rate, versus gastric cancer, which just has a partial response rate? I was wondering, because intuitively, to me, it seems that gastric cancer would respond much more effectively to cisplatin than bone cancer. So it seems kind of counterintuitive to me that bone cancer responds much better to cisplatin.
You're talking about cisplatin, right?
Yes,
specifically. So, I mean, I don't have the answer. I think the answer may be in the genetic composition of particular, lineage, like osteosarcoma, maybe expressing certain genes, and that's why they're highly susceptible. And gastric cancer is a very complex disease. I don't really know. Maybe, Adam, you know about osteosarcoma in terms of complexity compared to gastric cancer.
What I would say is that across cancers, there's a range of how much genomic complexity there is. The sarcomas do tend to be, in general, I don't know osteosarcoma in particular, but they do tend to be a little or somewhat less genomically complex. Gastric cancer and esophageal cancer are among the most complicated genomes, both in terms of the number of mutations, the number of typographical errors, and in terms of the number of copy number changes that are present. And so, often those tumors that are more abnormal can be more difficult to treat. And whether that's the reason, I don't know. But,
Thank you.
We have a question in the back of the room here. In the back of the room.
Yes, you talking about the immune system, you made a comment that the immune system maybe should attack the cancer because it was an unwanted cell. I guess you didn't say mutation, I think, but you made the comment I didn't really recognize, or why didn't it recognize it, because it's unwanted. I had heard other comments, though. The cancer cells are really an individual's own cell. It's not a bacteria, it's not a virus, it's not an external entity, and that was one of the problems, that you're really fighting yourself. The cancer is just trying to survive and killing the host in the process. Can maybe you elaborate on that comment that you mentioned today? Because you said the immune system maybe should attack it.
Sure, and perhaps others can also. So, you know, the theory goes that we are all developing these abnormal cells, many cells maybe every day, and there are mechanisms inside the cells and outside the cell to get rid of that cell. So the mechanism inside, if a cell goes haywire by accumulating genetic defect, then it's supposed to commit suicide. So if certain genes are intact, they will, like a P53, it will figure out that something is clearly wrong inside the cell, and it will facilitate suicide of that cell. So that is the internal mechanism by which the cell will be lost. And that's good for the host, because any cell that is abnormal, that could become cancerous and harmful to the host. So you have that mechanism, and people say that many cells in all of us are probably dying like this, are being cleared by that mechanism. Well, the second mechanism is the external one, which is the immune system. So if the genome of a cell becomes abnormal, it's supposed to put up all these abnormal proteins on the surface of the cell. So if there's something wrong inside, there is a flag outside. And the immune system is supposed to recognize that flag and then kill that cell. So people say that that is also maybe happening, that our immune system is clearing many of these cells who could become cancerous if you just leave them alone. But obviously, so many people develop cancer and immune system, so to speak, is intact. So why is that happening? I don't think there is a good answer. I like to hear other opinions, but as I was saying, that many of the features of the cancer cells are very similar to normal cell, and maybe immune system weighs more on the normal features and sort of ignores the abnormal features with the fear that it may be attacking itself, the host. But I think this is a very good area of research to figure out why people don't get bacterial infection, viral infection, fungal infection. They look very healthy. And they got a huge amount of tumor with so many abnormal proteins and DNA. So I don't really know. Does anybody want to comment on that?
Well, I think the whole, we have these checkpoints on our immune responses so we don't all, die of autoimmune diseases, because we're constantly being exposed to antigens and foreign proteins, and there has to be a balance in how we react to those versus mounting these huge immune responses every time we get challenged with a new antigen. And what the tumor cell appears to do is it exploits these checkpoints. It actually shuts off your immune response so that the cancer environment may actually be very immunosuppressive. And what these new drugs are trying to do is block these checkpoints to allow the immune response to develop. So I mean, these checkpoints are important. I mean, if we didn't have them, we'd all have, autoimmune-like reactions to every antigen that we were exposed to. So it's a balancing act, and for whatever reason, the cancer has developed ways to exploit this to shut down immune responses, and we're, hitting home runs in certain cancers because this seems to be an important driver in cancers like melanoma and kidney cancer.
So I think that's an important point, because people are now paying attention to what is called the stroma, which is made up of cancer cells, but also a whole bunch of normal cells that are thought to be helping the cancer grow, because cancer is recruiting all these normal cells. And also they find the T cells that suppress the immune system are crowding that tumor bed where there is tumor cells and a whole bunch of normal cells. So tumor is orchestrating perhaps avoiding, evading the immune system. It also makes this protein called PD-L1, and there is a drug against it right now, and it's showing promise in some tumors.
I know there's quite a lot of gastric cancer in Asia. Can you comment whether the gene changes are different in those people? And also, is anyone looking at long-term survivors to see how their genes are, if there's anything different about them from people who are not surviving?
Yeah, so I think maybe Adam should answer that. I know that the clinical behavior is different. The appearance of the tumor in general is different, Asian and the Western. And even the Korean and Japanese tumors have differences. But I think this is something is going to emerge quite a bit as we gather more data. So there is an international consortium that is doing the same thing that we are doing, TCGA. Maybe you can comment on that.
Yeah, no, I think that's a very good question, and something that people think about a lot and argue about a lot, because it's very often the case that within clinical trials that the responses to drugs in Western and Asian patients are distinct. Yeah.
Well, to that point, I mean, there's a very nice series that recently came out from Singapore, and it looks just like Adam's paper, you know, looking at the spectrum of genes that are amplified. And in this Singapore series, it was the same suspects that were affected. c-Met, EGFR, FGF, KRAS, same percentages. So I think there's a lot of overlap. And a lot of the differences between East and West may be the quality of surgery performed, or earlier diagnosis in screen populations, because it's now becoming clear that when you balance out things like quality of surgery and stage, that outcomes in East and, I mean, typically outcomes in the East are better stage for cancers, but as quality of surgery improves in the West, those endpoints are coming together. But it seems like some of these series, the genetic abnormalities are very similar, same targets, and so I think there may be more similarities than differences.
Yeah, I think that's definitely true. I think there's more similarities and differences. I would go back to the idea that we mentioned in my talk earlier, that through studies like the Cancer Genome Atlas, we're trying to put gastric cancer into categories rather than just being gastric cancer. And I think it's definitely the case that in the U.S. population, many more of the gastric cancers are at the gastric esophageal junction. And those are the tumors that are less associated with H. pylori. And in Asia, more of the cancers are in the body of the stomach. And the tumors that are in the GE junction that we have more of in the West tend to be a little more predominant in the ones that we call chromosomally unstable, the ones that have really, a lot of amplified genes and so forth. And so my suspicion is that we'll find is that there's different classes of gastric cancer, and that in the East and West, probably the distribution of subtypes might be a little bit different. I think because we have more of the GE junction tumors, we have more of that chromosomally unstable group, and I think that the proportion of some of the other subtypes might be a bit higher in Asia because they have more tumors of the body of the stomach. And so I think what we have to do is sort of correct for those subtypes. But my suspicion is once we do that, that sort of when you do an apples to apples comparison, the underlying biology will be very similar. But that's a good open question for the future.
Hi, I'm a public health physician. It's been a wonderful program. But could you describe some of the environmental factors or dietary factors that may contribute to, for example, across populations like the Asians to the United States citizens?
So, yeah, I think, again, this is a question for a lot of us. The cancer develops because of the interaction between our genes and our environment. Environments can be split up into two, lifestyle and then the rest of it where we have no control over it. So if I walk outside of the hotel, I don't have any control over what I'm going to breathe, except I can go back to Texas. But I have a lot of control over what I eat, whether I exercise or not, and a lot of other things. If you look at the Japanese population, of course, there is this genetic component and then interaction with their own environment, and a lot may have to do with soya sauce, like high salt diet, or nitrated foods, smoked foods. Some of the other things, like if you eat a lot of meat and don't eat a lot of vegetables and fruits, you're considered to be at high risk. And also smoking has something to do with gastric cancer. So I think those are the things. H. pylori is a very big, major factor, and that also is being addressed by the Japanese government now. So I think when gastric cancer was very common here 60 years ago, we probably had a lot of H. pylori, and we have eliminated that by sophisticated lifestyle, preservation of food, and better hygiene and better quality of life. So that's what I think. Maybe there are more comments about it.
Well, there's an increasing area of research that just your own genetic makeup, like, how different people fight off a Helicobacter infection. There are different, how your immune system reacts, the kind of cytokines and things that your immune system produces, that depending on your genetic profile, you might be more susceptible to develop a gastric cancer from Helicobacter than a patient with a different genetic makeup. So it's not just the Helicobacter infection, but it's your own makeup that determines how you fight it off or how you react to it, and whether you're going to be at higher risk to develop cancer. So it's very complicated, so that it's not just the bacteria, but how the individual handles it as well.
Do we have any other questions? We have one question over here and another one over here. Go ahead.
Hi, I just had a question about timing, when to try to get genetic testing to see if genomics can help, when to see whether some of the other forms of treatment you're talking about and discussing may be helpful. I think I've been through 10 rounds and I feel good, and I don't want to wait too long to maybe explore the other possibilities. So I don't know if you have comments about that.
So there are two forms of genetic testing. One is the DNA that you got from your mom and dad. So that's called the germline. And you should probably visit this nccn.org. Look at that document. I think that will give you some guidance as to whether you should see. So what we do is we will identify certain high-risk patients and families, and then we have a group of trained geneticists who do what is called genetic counseling. They don't do testing first. They will just sit down with the family and kind of figure out whether is there a high risk, is there something being passed on. And once they determine that there is a reasonable risk of something is being passed along, then they do the testing. So that is for risk for the rest of the family. But the genetic testing for your tumor is something that there's a lot of variation. So I have done, like, there are companies and there are genomic centers, like Baylor College of Medicine in Houston. They will do testing. You send patient's tumor to them, they will tell you what are the structural abnormalities in that tumor. Or you can send it to Foundation Medicine, but there are many others. And after doing it in about 150 patients, I didn't really find it very useful. I think we have to kind of regroup and figure out, but my institution is now pushing to do it in everybody. And they are providing funding for it. So, and I think different institutions are doing different things. But in general, it doesn't seem to be, to be able to select a new treatment for a patient, it doesn't seem to be that good at the moment.
I mean, the problem is that a lot of the genes that are identified, we don't even know what their function is, and there aren't drugs available to test them. So our center also, we're trying to do, most patients as they walk in the door, because even with that caveat, there's a small percentage of patients that have actionable gene mutations, and they might be a candidate for a trial now or later. So I think we do order this testing, but what I tell patients when I order it is there's probably a 95% chance we're not going to find anything that we can really act on. And then Adam also made the point, I think, very nicely with his slide, is just because you identify gene X is affected, it doesn't mean drug X is going to work. We've already learned that even in other cancers, just because a particular gene mutation, drives the cancer process in one cancer, it doesn't mean it's going to drive the cancer process in a different disease. So a good example of that is the BRAF targeted drugs in melanoma. 60% of melanomas have BRAF mutation, and that the BRAF directed drugs are quite effective. About 10% of colon cancers are BRAF mutated, and you give a colon cancer patient a BRAF drug, and 1 out of 30 responds. So it's really a work in progress. We are doing this testing, but the problem is we don't usually identify things we can act on, and we try to do this more in the context of looking for screening patients for studies that have drugs that might help patients. But unfortunately, more often than not, it's not a useful exercise.
You have something to say about that?
I largely agree with everything said. I think from I have a little more optimism here. Of course, this is what I do. But I think that as we look into the population of tumors, I think there are reasonable numbers of potentially, and I use the word potentially, actionable findings. In many cases, these are related not necessarily to drugs that are in practice, but in development. I think the issue is, and I think this came up very well from the point that David Ilson just made, is that I think is that sometimes what we're seeing is that in tumors like gastric cancer, one drug is not enough. And so sometimes you find something actionable, and your temptation is, let's give a drug that will block that, and that one drug isn't enough. And so I think then it doesn't work. And I think that then creates the temptation to think, well, let's throw the baby out with the bathwater and say that, we looked, we saw a mutation, we gave the drug, it didn't work, let's move on to the next thing. And that same, I think the example of BRAF and colon cancer is a very good one, where there was this gene called BRAF that's mutated, and in melanoma, you give a drug that blocks BRAF, and that drug is highly effective. It's transient, but highly effective. And that exact same gene, that exact same mutation, that exact same drug was not working in colon cancer. However, people have gone back into the lab and looked at this question and said, okay, in a colon cancer versus a melanoma, when you have the same gene, the same drug, in the colon cancer, the tumor does something. It sort of has a little way it works around, and it turns on a second gene. And so now people are looking at the combination of hitting both BRAF and the other gene, which they think is the escape path. And so I think, I think so it's a complicated. I think that, often as you do this testing and you find those genes, they can sometimes point to something that's an idea. Oh, you should try a drug that blocks this. But, but I think what we're going to probably see is that in many cases, if you just say, okay, let's give that one drug that blocks that one target, we're not going to be effective. But then I think the long term is to really sort of figure out how to play this game of chess and learn how the tumors are going to work around that. And I think as we can do that, and we could figure out how to develop these rational combinations, there are a lot of actionable events in these cancers, except it's going to be complicated because they're not going to, they're not going to respond as simply to one drug for one gene. And that's going to make the effort of actually developing these therapies challenging. Yeah.
You have a question?
Yes. Oh, hi, good morning. I have a question for anyone on the panel. We all know that stomach cancer is on the rise in young people and that the likelihood of being diagnosed between the ages of 25 and 39 have increased by over 70%. And I just wanted to ask if anyone had a reason for this. Why is this trend occurring?
So actually we don't know for sure. I mean, there may be multiple factors for that, but there was an analysis from the NCI that suggested that an increase, a very small fraction increase was not dramatic. It just depends on how you do the numbers. But we thought that it may be because of the immigration from the Eastern Europe, because it was in Caucasians, young Caucasian males particularly were having this cancer. But we couldn't get an answer to that. So we don't really know, but our environment is changing so much. A lot of pollution and a lot of processed foods and different lifestyles. So I don't know if somebody has more to add.
What is the implication of eating charred protein?
What's the implication of what?
Eating burnt, charred protein.
Oh, that's bad for you.
Yeah, you'd starve in Texas if you didn't eat charred protein.
Yeah. So it's just nitrosamines, I think is, you just take a good piece of meat and add, you create some carcinogens in there. I guess those are toxins to your stomach lining, basically. So let's not do that.
We have a question?
Along the same lines of the question that the young lady asked over there, I know that the stomach cancer is very prevalent in Hispanic, Latino men. Can you give me some information on that?
So that is very true. And South America, like Chile, the #1 cancer in men is stomach cancer, and #2 cancer in women is stomach cancer. Same thing in Peru, Costa Rica, the whole belt, all the way to Central South America. And the only thing we can really blame is H. pylori, but there's got to be a bunch of other factors, including, of course, what I mentioned before is the genetic pool. So that interacting with the environment. And H. pylori is very, very common down there. I can't think of any particular type of foods. I've been there many times, and I really can't think of any kind of food particularly. There's a lot of poverty there, so H. pylori story comes back.
Any more questions? Okay, well, thank you very much, Dr. Ajani.